Hello, I'm Kirk Pinto. I'm one half of the Office of Physician Wellbeing at Cook Children's Physician Network.
Hi, I'm Sara Garza, and I am the other half of the office.
So our office was stood up because of some rumblings in the staff about burnout and a big interest in burnout among medical staff across the United States as medicine became more corporate. So what we're supposed to do is sort of identify what are the causes, the drivers of burnout at our institution, and sort of mitigate them as best we can. And we've done that from systemic things to individual pebbles in people's shoes. And it's a big job and it's ongoing.
So our office was formed on the tailcoats of what we started in sort of a more communal setting. We had the Physician Wellness Committee in the beginning that we originally called, what was it called? Home for Dinner. Home for Dinner, which was ironic because we were never home for dinner. The meetings were always at 6:00. So because it was a volunteer committee of physicians from primary care and specialty care, and that was the time we could meet. So that was a group of physicians that came together to really start talking about what was going on in our profession with respect to pressures, not just from, caregiving, but from the corporate side, as Dr. Pinto alluded to. So the expectations from patients and families, the expectations from the organization as far as administrative work, the expectations from regulatory agencies and legal, and all of those things came to exert an inordinate amount of pressure on physicians that hadn't been in existence really before, as sort of the climate of healthcare changed, as our culture sort of evolved into what we are living in today. And so the group of physicians came together to look at, what is it that we could do to help decrease some of those extraneous pressures that really take our focus off of what we were called to medicine to do in the first place, which is care for the children and try to help navigate their well-being and their own health, their journey in health, while not sort of suffering and burning out ourselves. So the focus of our office is, as Dr. Pinto alluded to, is mitigating burnout. But also, really, I'd like to flip it and talk about how do we really promote the well-being of our physicians? How do we get to a place where we really are thriving and doing what we love in a way that is supported by our system?
And it comes to at a time when there's a new realization, more than 50% of physicians now are women, and that's even higher percentage here at Cook. And so women heretofore had been at home taking care of domestic things while doctors were gods and men and just did whatever they wanted as long as they needed to. And now this idea that there was a life out there, that you weren't only a physician, that you were also a human, to put those two together, magnifies all the stresses that Dr. Garza was talking about. And those things just have to eventually come to a head and have to be dealt with. And that's sort of where burnout comes in. It's that sort of uncontrolled, undealt with stress that eventually does bother folks and bothers them in a profound way. And there's no going back. We're not going to go back to the time when doctors did whatever they wanted and ignored their families, and which was the sort of high on a hill image of a physician standing at the prow of the boat, just doing whatever he could for the patients. And when I say he, it was literally always he. Those things have changed. I think everyone acknowledges they've changed for the better, but all that sort of social pressure that swirls around everything else you do in your life, that has to be fit in as well. So that's the now phrase work-life integration, to make sure that you can be a human and a doctor and they don't stop at the door of the hospital. And it's that sort of mixing of those two worlds that it really is the source of a lot of the angst that people feel and a lot of the burnout people feel. And so we sort of try to make it so that, the work is definitely hard, but the job doesn't have to be hard, that we can tear away those things that are unnecessarily burdening them.
So I got to this place in the Office of Wellbeing on a little bit of a long, winding path, I'd say. And what I mean by that is I landed in medicine because I knew I wanted to be a pediatrician. only pediatrics. I was only ever going to be a doctor if I was going to be a pediatrician. So that's the first part of how I got to this place. How did I get to the place where I was going to be a pediatrician is a little bit more of a winding story as well, in that I grew up in a family of 4 girls. My parents immigrated from Cambodia while my mom was pregnant with me. And they ultimately landed in Texas because she wanted to be in a place that was in a climate similar to where she grew up. And it was hot in Texas. That's what she knew, so that's where we went. And so I don't think that was by accident to any degree, because, again, as I said, she was pregnant when she came here, and they are Cambodian, so they're Buddhist by background. But when they came, they were sponsored by a church in Richardson called King of Glory Lutheran Church. And there was a group of families there that sponsored refugees from California at the time. And so they sponsored them here. And I say all that to say, when my mom had me at Richardson Memorial Hospital, they had no name for me yet. And my older sister, she has a Cambodian name. And my family had newly arrived in this country, and so they thought, well, what do you name your kids here? And so some of the church members were just like, Sarah. And so that's how I got my name. And knowing that about me, that namesake was not anything that was from our family. That was sort of part of our immigration story, I'd say. And then, growing up, we were a very close-knit family. My sisters and I are pretty close in age, and we didn't have a lot, but we had each other, and we had a lot of the things that a lot of immigrants families have to deal with. I'm a Gen Xer, and so we did a lot of the, go play outside until it's time to come in, and take care of our responsibilities, knowing what they were set forth, and we were, quite set free to handle them on our own. We were expected to do that, and that's just what we did. Like I said, in that generation, we had 2 working parents that had to be out of the house, so we were latchkey kids, and we came home from school, and we had to, manage ourselves, unlock the door, like with a key code combination kind of a deal, and lift up the garage door, and walk home from school, and do all of these things. And so that was just part of growing up. We were very independent. We were very capable of, sort of managing ourselves to some degree, but with each other. And so we had that very close-knit family where we just depended on each other. And my father was very strict. He's I guess I would say, a prototypical Asian father, in that, he knew what he expected of us. He was very clear on that, very firm on what our boundaries were, and we didn't truly cross those to any degree. So my dad was pretty strict, and although I was, always kept up with my schoolwork and I was a really good student, I also had other interests. I remember in middle school, I had transferred from one middle school, which was called Longfellow Leadership Academy, or something to that effect, Career Development Academy, I think. It's in Dallas. So I was in Dallas Independent School Districts, and we had to get bused to that school. And I went to that school because I was like, okay, I don't know what I want to do. I'm going to go to this Career Development Academy. And so I got to see a ton of different things. I started playing the flute. I started doing things in art. I started, looking at things with respect to math careers and all of that. And so it was a really cool opportunity, and I enjoyed my time there. But my dad decided that he wanted me to go to the Talented and Gifted Academy. So the 8th grade year switched me over to that school, also in Dallas, which was like, a little bit of a hard transition, middle school girl, switching schools midterm and acclimating to that and learning about all of that. But it was really interesting how it all worked itself out, because we were able to go to the museum districts, and I discovered a love for art and a love for performing art. And so it was just exposure. It was like new exposure, new new things that we had never seen before. And anything within the scope of school was on limits, as opposed to everything outside of school was off limits. And so I was like, you know what? I'm going to figure some stuff out through school. I am going to get involved in everything that I can through school, because Dad will say yes if it's related to school. And so as a kid like that, you want to stretch your wings and you want to figure some stuff out. And so that's how I was able to do that. And I learned more about myself in that way, and enjoyed the creativity. But I will say that that ongoing sort of immigrant mindset and pressure to kind of succeed financially and be able to provide for yourself and all of that was always something that they instilled and wanted to ensure that we were able to do for girls. You got to be able to take care of yourself. And so my math and science were always a strength for me. I enjoyed all of the other creative arts things, but what are you going to do when it's all said and done? And so I went through the litany of things that you could possibly do in that, and I worked from the time I was 16, and so I had lots of different exposures. I worked, my first job was in Eckerd's, which is a pharmacy that doesn't exist anymore. But in Eckerd's, as a 16-year-old or 15-year-old, I think I was 15 or 16, what you can do is mind-blowing now. I ran the registers, I dispensed cigarettes, I helped with dispensing medicines in the pharmacy. They had a post office there. You stocked the shelves, you emptied the bins, like everything from soup to nuts. So that was really cool to just kind of see. And what I learned from all of that, and as I entered my high school career, was that I really loved interacting with people. I liked helping people. I liked kids, but I didn't like kids by themselves necessarily. I didn't want to take care of kids necessarily, but I liked kids together with their families. And so all of that, and then I did some other things, I did research. I thought, okay, well, maybe I'm going to be a research scientist, and I like that. So I did some of that, and I really enjoyed that, but I was like, it's so lonely. You're there by yourself, and you're doing experiments, and it's very rewarding, but it's so slow, and it's so lonely. And so I thought, okay, that's not it. And eventually, it came to the realization that I wanted to do something with kids, but not by themselves, and not be a primary sort of caregiver for them. And then so that's where pediatrics came into play.
So my story's a bit different. I grew up in New England. I'm a second generation immigrant. My family mostly from Portugal, and also was, as immigrants are, expected to sort of do stuff and succeed. Although my parents were pretty trusting, and they let us sort of make our own mistakes, which I've made plenty of. So I went from a public high school, and I went to I sort of forgot to apply to college. So the last week before because I had no parents that went to college. So the last week before you're supposed to apply, my guidance counselor called me in and said, "What's the story?" And I said, "Well, when do we start?" He said, you got a week. And I literally looked over his head at his pretty Latin purple diploma. And I said, "Where'd you go? That looks good." And that's how I picked my college. So that starts the academic rigor of my life. But it was a great college with Holy Cross in Worcester, Massachusetts, a Jesuit school. I had fun there. It straightened me out. I went there majoring in journalism. In the midst of that, I switched to psychology, and I obviously have a job in either one. But I graduated in the 4 years and didn't know what I wanted to do. I went because Houston was hurting for teachers. I was a volunteer sort of teacher in Houston, emergency certified. And I taught high school in Houston, which from a guy who spoke like a Kennedy and went to a school that had 180 people in it, period, to go to literally the worst high school in Houston. Even back in the 80s when it was a pretty bad place. And they had their own police force. I could hit kids if I wanted, or paddle them if I wanted. It was an entirely different world for me, but I enjoyed it, and I learned to say my R's for the most part. But I also found out I didn't like working so much. So I decided I would go back to school, moving from Massachusetts, which is a pretty high-cost state, to Texas, which is a lower-cost state. I was a resident in both. I got in at University of Massachusetts to medical school. I chose medical school because it seemed the longest, so it would keep me out of work. So I chose medical school. I got into UMass, was about 8,000 then. I got into Texas Tech University here in Lubbock, and it was $250. That was my tuition. So we are not rich people. I took loans out for my entire college. My parents could not. It wasn't that they wouldn't help me, they could not help me because we weren't financially very affluent. And so it was an easy choice to go to Lubbock, which also I enjoyed as much as I enjoyed Holy Cross. It came time to sort of pick a residency. I do not want to go to work. What's the longest residency? The urologists were nice. They were funny guys. They wore pajamas every day. And people have to tell urologists things that automatically puts them off balance. So that I live in that world of sort of making people feel comfortable, I think, with telling me goofy things. And so I went to urology at Wake Forest. 4 years after that, 5 years after that, now it's time to go get a job. I don't want to work yet. What's the longest fellowship I can do from here? Pediatric urology. I had never had any. I never wanted to be a urologist. I never wanted to be a pediatric urologist. I just wanted to avoid going to work. And so I ended up in Memphis at St. Jude and Le Bonheur and did pediatric urology fellowship there, which I enjoyed also very much, all of this. And when it was time to get a job, I had dragged my wife, as most of us do, all over the country to now we're going here, now we're going there. You guys deal with it because this is what I'm going to do. So she got to decide, or at least participate in where we were going to go. Much like Sarah's mother, my wife grew up in Cleveland and Michigan, and so she drew a line, it needs to be warm. She was honorary Cambodian, I guess.
That's right.
And so we ended up in Fort Worth, and that's how I got to Cook. The Office of Physician Wellbeing was set up by the prior president of Cook Children's Physician Network, who was a man named Britt Nelson, who'd been there a long time. And he had lorded over the building of the network to where it originally started just as a billing entity with very few doctors. And most of the doctors worked at Cook, but not for Cook. And so one of the things about burnout is it thrives in corporate environments. People lose their autonomy, people lose their ability to sort of direct their own lives. And Cook saw pretty quickly that they were going to expand by sort of employing physicians. So they built expensive machines. They needed a ready source of patients to get there. The only way to guarantee that was to have the doctors under employment. And there's pros and cons to sort of corporate medicine. But in 2024, it is what it is. I mean, Cook's is now almost entirely consisting of employed physicians. And so there were attendant problems that he noticed, that people were not as, they didn't seem thrilled with their bosses here. They seemed disgruntled with the work, even though it was exactly the same work, but it was new corporate pressures. And so he decided that we needed to look into that. And he started the aforementioned Home for Dinner Committee, which is a way to sort of see what this was. And what it came to be is that they began to understand that the problem was burnout. And they had inklings of that, but they had no real sort of firm measure of that. There are measures of that. And so just prior to our being able to form this office, the network gave to the physicians only the Vanguard test, the gold standard test for burnout, the MASLAC survey, which showed even though Cook felt that everybody should be or is happy to work here, everybody loves the job they have, the test showed otherwise. And so that was an impetus for them to say, well, we better take care of this.
So from the idea of developing the Office of Physician Wellbeing, we knew that doctors really want to be able to do what they're trained to do, which is take care of patients. And there were a lot of things that were getting in the way of that with respect to new administrative burdens or expectations from different sources, the EMR, all of those things came into play. And so it sort of put a separation between what a pediatrician or a pediatric specialist was passionate about doing and not just their patients, but, what they were able to do even outside of the workplace. So there was this huge sort of barrier to being able to be fulfilled in your career, not intentionally. I mean, all the things that were put in place were necessary, but there seemed to be not a streamlined way to practice good quality medicine, to be able to connect with your patients and have the relationships that we want as pediatricians to have with our patients and families, and be able to go home and spend time with our own families. So we wanted to reconcile that. We wanted to start finding ways that in in the milieu of where we are in healthcare right now, how do we get doctors back to the place where they can do the doctoring, building those relationships, providing the expertise of their training, and practice the art of healing, honestly, without the distractions, without the pressures. Like, how do we create that sort of bubble within the patient interaction and sort of get rid of all the extra noise, literally. So that's part of what we are doing. We're looking for ways to support physicians from a system perspective, create an environment where we can, so to speak, create that bubble for physicians to do those things, to be able to practice in the way that they are desiring to practice, with their skill set, with their experience, with their own practice style, and be able to do that and get home and have a life.
Yeah, and this all grew out of the fact that the business people who run the hospital now and the doctors who run the care now really didn't coordinate. What we're doing now is sort of should have been done at the outset. The fact that producing more is a bedrock standard business practice. It ain't good for care to try to just jam more patients through a clinic. Filling out all this paperwork is a standard practice. I know where every dollar that I spent went. That's not necessarily the best way to practice medicine. And so the idea that the business people are, I think, I'll give them the benefit of the doubt, they're well-intentioned, but they're applying business practice as something that doesn't necessarily fit. And on the doctor side, for the most part, or at the beginning at least, we just resisted it. It wasn't the idea that we'll ever sort of marry these two. It was the idea that this is doctoring and it's sacrosanct and nobody else can come in here. And now I think both sides have realized that there needs to be some cooperation, and offices like ours and many offices at Cook particularly are staffed by physicians because and it is a tacit sort of realization by the administration that we don't know how this goes. We don't know the best way that this goes. And it takes some time for the administration to sort of loosen the reins a little bit and to understand that we're all sort of trying to pull in the same direction, because at first, if you give the prisoners the key to the prison, things may not go well. But for us, I think they have gone well, and we've been able to articulate goals that we want to move to. So it's not just the business people being nice to us. It is essential for business that these employees stay happy for a lot of socioeconomic forces, especially in medicine. And so it could be all altruistic. We just love doctors. It's probably not. It's partially business. They did it wrong, and not only Cook, business did medicine wrong, and they're having to dig their way back out. And that's where sort of we live, to sort of straighten that crooked path.
I think the easiest way to understand burnout is where the demands that are placed on a physician, well, if you're speaking about the physician burnout, the demands placed on a physician are overwhelming compared to the resources that we have. So resources like time, resources like emotional capacity, resources like financial resources, all of things within a clinic that you need to support a physician's work. So nursing staff, so, appropriate EMR support, all of those things. So if you are dealing with like having to take care of patients and your main goal, I'll speak from my perspective in primary care pediatrics, it is such a unique place because people are bringing their children to you. And within the confines of that office visit, it is completely sacred. Like, you cannot imagine as a general pediatrician what stories you hear from patients and families. It is incredible the trust that patients' parents put in you to share not only about what's going on with their children, but about their family, because it's all related, right? And so to be able to have that trusting relationship, you have to have the time to do that. You have to have time to build rapport. You have to have time to allow people to know that you are there to support them, to walk along through this journey of health with them. And so without that, the pressures of, having to see, 15-minute appointments for a checkup or a particular visit, sometimes that's not sufficient. And so allowing ways. So I'll tell you, in my own practice, when we switched over from paper charting to EMR, I didn't want to lose that relationship bit. I didn't want to lose the ability to talk face to face with patients and families. And so I chose to have a medical scribe where, my scribe would sit in the corner and quietly take in all of the information and enter it into the documentation part into the chart. And so I was still able to have that face-to-face engagement and interaction. And so supports like that for physicians are incredibly helpful, things that are coming along with respect to technology to help bridge that gap, to allow us to be able to do what we really need to do to be able to build those relationships and allow for us to cognitively think about what's going on, to figure out kind of what's going on with the patients and families, to convey what we're recommending. All of those things are necessary to have in that space. And so burnout is, different for different people, for different specialties, but in essence, it is that demand resource mismatch that can lead to getting emotionally exhausted. That can lead to, okay, I'm not effective at what I'm doing anymore because there's just no time to do what I need to do in the right way. I just can't be effective. I'm doing what I can and I'm like spinning, going, and I just can't get it done. Like that level of lack of accomplishment, personal accomplishment is a key factor. And then ultimately that can lead to depersonalization. You're just like, you're trying so hard to do the right thing, trying so hard to help the people that you really want to help, but it's not enough. There's just not enough. And so it sort of like gets you in a place where you become a bit more jaded. You feel a little depersonalized. You feel like, it's a lack of control. It's all out of control. And so, it happens in different ways. You come in and out of burnout, in and out of the factors of burnout. Like there can be seasons where, you're doing well and your emotional depth is good and you're not feeling that. But there are going to be seasons where you're just kind of like waxing and waning throughout that. And so it's not just a stagnant or a static problem. It's a dilemma that is sort of ongoing. It's something that we have to kind of look at. What are the pressures? What are the demands being placed? And what are the resources that we have to kind of support physicians to do what they're called to do?
And it's different than it used to be. I mean, back in the day, and there's still there's still some memory of the indefatigable God doctor who would come in at any hour of the night and do whatever they needed to do. The fact is that demands of physicians have changed quite a bit, and that model just isn't going to fit anymore. We cannot, those doctors that walked the halls before didn't have the amount of data that we have, didn't have text messages from their patients, didn't have 24-hour clinics, didn't have all those things that we have now. So the idea that we could do the lesser amount of work that they did before with the same vim and vigor applied to the enormous amount of work that we have now, it's just not a good idea, and it's proven not to sort of work out, and that's why we're here. The other thing that's sort of confounding everything is this, anything that isn't physical. So as a urologist, we are known to sort of x-ray everything 10 ways. We never cut the skin without knowing exactly sort of where we're headed. And so there's no way to sort of x-ray someone and find their burnout, or to understand how two people in the exact same office, one of them whistles and goes home every night and happy and the other one doesn't. And those things sort of breed a feeling of, well, maybe they're faking, or maybe they're weak, or maybe but not everybody likes ice cream, and that's an amazing thing. Everybody is different, and there are people in in literal harm's way with the amount of work and the amount of demands of their work that don't do so well, and there are other people that face that and are very resilient and do well. And if the situation flipped a little bit, they would trade places. So it's an idea. This office and Sara and I have to sort of remind ourselves we have to be very accepting, meet people where they are, because everybody's going to have problems. And it speaks to what I spoke about before, is very little part of their life, and there's a lot of other stuff going on, and that stuff all washes into what they do at work, and it's the culmination of all that stuff that either is a placid river or a volcano erupting, and it's different for different people, and you have to trust that they want to do better, and you have to sort of lead that there. Now, we're not personal therapists, but to the extent that the administration puts a heel on them, puts a pebble in their shoe, again, maybe unintentionally, we didn't know this was going to generate so much work. We didn't realize that this was something we made up, not really a regulation. Those things happen, and when you are at the computer all day filling out paperwork that really doesn't move, as Sara said, the health of the patient, it can wear on anybody. And our job is not that therapy of those struggling people, although there's plenty of resources for them. Our job is to one step back to say what sort of is pushing all these people to these bad places, and to the extent that we can, within regulation, within rules, can we get those monkeys off their back, and that's what we spend the bulk of our time doing.
Mm-hmm. With respect to demographics and the highest rates of burnout within medicine, I would say that female physicians in their mid-careers are one of the highest groups of burnout, and that is multifactorial. And burnout is something that manifests, it's a workplace issue, pressure, dilemma, right? And that's because we are whole people, but we are also expected to be able to do, our doctoring within the confines of our professional workday, but that doesn't stay confined within your professional workday in medicine. It's not something that you clock in and clock out of. It is something that is, that bleeds into other parts of your life, and naturally so, based on sort of the type of work that we do and the responsibilities that we have. Basically, the buck stops with us, essentially. And so the reason why my particular demographic is at the highest rate of burnout is because, again, we have the demands and pressures within the professional life of work. Then you think about, what does your world look like outside of work? We go home, we have our families, young families, teenage kids, young kids. We have all of the relationships that we have to maintain outside of the home, let alone, caring for ourselves, caring for our aging parents. So we're in that sandwich generation where it's like we've got our kids to raise and we're still in the midst of that. We're, within our own nuclear family, within our marriages and with all of that, plus our extended family with our parents aging, and having to sort of navigate what that looks like, and starting to, where your parents were historically more caring for you, it's flipped. You're more caring for them and worrying about what is their cognitive, status look like? Are they able to kind of live independently? Do we need to take them in? What are those kinds of things? And so there are a lot of demands on a human, just on any person. But for women, we traditionally still have a lot of things that we're expected to do and are responsible for. That changes, and it sort of depends on your family and what that looks like at home. Some people may have more support, some people may have less, where they are still, primarily caring for the children, primarily caring for the finances, for that, academics for their kids, all of those sorts of things, and then dealing with their families. And some are single parents. And so I think that's part of why burnout is so prevalent in that particular demographic. And then as a female physician, you think, okay, I'm a pediatrician, so I should know how to take care of kids. I should know what to prioritize and that sort of thing. But you're pulled in many directions. If I choose to do this with my family and spend time with our kids, then what gets shortchanged? Does it have to be? And so that comes into the whole concept of work-life integration. Work-life integration is like one of those, it's not a new concept, but it's more sort of like spoken about now. And that's partly past the pandemic and people doing more virtual and, flexible work. But that's part of like, how do we actually manage the work that we have to do? So I would speak for myself. When I finished up in clinic, I still had charts to do. So I would just go home, take care of my family, put the kids to bed, spend quality time with them as much as I could, then stay up and do charts. And that's what the majority of us, chose to do so that we could have that integration. But, can there be a better way? Is there a better way? There should be a better way. And so that's part of where I'm so passionate about looking for that. I didn't have that for a long time in my career as a general pediatrician, but I knew that there must be. I knew I had many ideas for how we could make the system better, how we could do this better. I didn't have the time. I didn't have the bandwidth to correct it. I didn't have the voice of like all the other pediatricians and their input. I didn't have the input from the other stakeholders that it would involve. But that's part of why I'm particularly so passionate about this, is because, we have the opportunity, especially as women physicians are the majority of the pediatric workforce now. How do we make it not only feasible for women to thrive and be successful in their careers, but also at home? How do we really support them in such a way that they feel good about what they're doing and doing an excellent job in the world of caring for children, but also in the world of their being a mom, being a wife, being a friend, in their relationships outside of medicine. So I think it's something that Kirk and I both are really passionate about in different ways. I think it's very unique, our office, in the way that it came about. I don't know that there's any other system in the country that has essentially the roles that we have. We're associate physician well-being advocate and physician well-being advocate, and we're two parts of the same office, but our perspectives are so unique because, again, I'm a general pediatrician, female, mid-career. He is a, boomer, getting, up in his, maturity in his career. And
I wondered how that was going to be phrased.
And a specialist, a pediatric urologist in the specialty world. So he sees a very different lens. He sees the world of the surgical, field, the world of specialty practices. He travels to Amarillo by plane, and he has such an expertise that's needed, and he gets pulled in a million different directions, and is also a medical director for his department. And so he has a very different perspective than I. And we also happen to be very different in just our personalities, but I think it's very unique, and we work so well together because of that, I think.
Yeah, I mean, to your question about sort of who gets affected by burnout, every generation believes that the generations behind them are weak and they can't hack it, and that's the problem, that we're going to keep raising what do they call them, wilting flowers that won't be able to stand these pressures. But as Sara eloquently just said, it really goes by your personal responsibilities, right? That at my age now, thank you for your reminding me, but at my age now, I don't have my kids are out of the house. My house is paid for. My financial pressures are down. I have established my career. I'm not fighting to sort of get patients. And so the band of biggest burnout continues to stay near those beginning their practice and those in Sara's with Sara's responsibilities now, that absolutely your home responsibilities affect because of this work-life integration, which in the 60s, because I keep going back to when doctors were gods, was called work-life interference. That was the literature, because one should not overlap into the other. And then it's not a surprise too that the other sort of group that is badly affected by burnout are minorities. They seem to always be on the bad end of everything. But there's recognition that minorities, although they're a bigger part of medicine than they were, they're not as big. They're not represented equally to their representation or their numbers in the population. And so they feel like they're representing the entire. I'm the only Mexican physician here. I'm the only Black physician here, and they have a bigger sort of outsized responsibility. They feel not just for what they're doing here, but for all those people that will come behind them. And so those things, those people are at risk for burnout. Older folks aren't necessarily. figured out what medicine looks like. We've established all the things we need to establish. It's not that we're immune from burnout, because there's other things. The administration could give us enough work to make it overwhelming, all those things that Sara said before. But as a rule, it's those sort of people who are in the beginning to the middle of their career, and especially if they have a lot of outside responsibilities that sort of overlap and waft into their clinics during the day, because frankly, you don't leave your personhood at the door when you become a doctor, or vice versa. It all sort of mixes together.
You know, what you say reminds me about something too, is that talking about burnout, and it's so hard to imagine people getting to medical school and becoming a doctor is no easy feat, right? It's like 4 years of college, 4 years of medical school, 3 or 4 years of residency training, and then if you do fellowship, it's that. Then if you do a specialty fellowship, it's even more, as in Pinto's story, right? But with burnout becoming so ubiquitous in medicine, people like wanting to leave the profession after like a decade of academics. Like, how can that be? It makes no sense. Something that you were called to, something that you were passionate about, and then the pressures of it and not being able to reconcile that, it is insanity. So I'm like, that's part of why we're passionate about it.
That's as good a evidence that it's not that the profound nature of, it's not some toss-off term where we don't know what else to call it. It affects people badly. I mean, it is not a direct cause of suicide, but it's the top of the slide, and unfortunately, and so there's very good evidence this is a serious deal, and it's the financial evidence of, I worked so hard to get to this job, and it is so suffocating to me, I need to get out. And hopefully, if they're going to get out, they just quit, because there's other terrible ways to get out, and we need to, as best we can, sort of stop that. The idea in the past was that you were a doctor, and if you had time for other stuff, you would incorporate some of that other stuff, but it wasn't your priority. And what has become generational, and Dr. Zurich, who does the hiring for physicians, and we speak to some of the physicians who want to be hired here now, the newer generations, the younger generations have sort of figured out that they do want some work-life balance. If you poll doctors after they've retired, and you ask them, now that you have the lens, you can turn around and look back and see what you liked, what you wanted to do, all of them say, I would rather spend more time with my family. I would rather spend more, the roughest, toughest guys, the most masculine, macho guys, the general surgeons, heart surgeons, all of them say that. And at the bottom of that list is, I wish I made more money. And when you look at people plowing through this, they sort of flip it. And but generationally, people have begun to realize that I am going to be a doctor too, but it's not going to define everything that I am. And we do things different. And when you talk about how it affects men differently, if you look to go back to buzzkill of suicide, if you look at who dies by suicide in the general population, it is a young man's game. It is a lonely man's game. It's usually someone unmarried, unattached otherwise, and very young, in their 20s, 30s. In physicians, it is an old man's game. It is someone who's over their 50s, generally married, usually pretty far along in their career. And so we have to be awake and alert to the fact that this, again, is not just something, it's not just a phase or a fad that people are paying attention to. It's a life-threatening disease. Again, burnout is not depression, and burnout doesn't necessarily leapfrog depression to get to suicide, but it is on that continuum. And if we can, and certainly if you can put out a fire with your heel, rather than having to call the fire department, that's a better way to do it. And so that's, sort of where we live in that. But it does not, for all Sara's points, it does affect women more, but it affects men also at a higher rate than it should. And again, white men are sort of more immune to it for a number of societal reasons that I don't want to start arguing about. But I mean, the facts are the facts. And so it's better to be a man in terms of burnout. We don't have we're not expected to do all the jobs at home that even physician women are expected to do. And so all those responsibilities that we've outlined are lesser for men, but plenty of men are affected, and it is just as important that we take care of it there. My work in burnout, I sort of came to honestly, because I went through a period. It sort of fits into with my laziness that I didn't always want to work that hard, but I was in a funk pretty quick, and that I now recognize as burnout. And so I did not want to do this job anymore. I literally was walking around an American Neurological Association meeting with someone, one of my friends from another institution, who I was telling this exact stuff. This job stinks. I mean, and he's like, didn't you always work there? I did, but something has changed. I did my training in Memphis, Tennessee. I came across a booth where someone I knew was sitting there. I didn't know why they were there. I started talking to them. I stepped back to look at the booth. Why you're here? It was for a business school at University of Tennessee in Knoxville, the Haslam School of Business. He said, we do truncated 4-physician medicine associated MBAs. And so never had thought of going back to school before. Certainly had thought of ever having an MBA. I never did any business in my life. I signed up because I'd said, this is what I'll do. I'll have to do something else. By the grace of God, I sort of learned about burnout through that. I did some research at the hospital where I accidentally talked about burnout, fell into this committee, and the rest is sort of history. But it was profoundly interesting to me what I found. It was profoundly sad to me that unintentionally the institution had imposed such sorrow on people, and that I saw. It was palpable to me, and I say unintentionally because once we sort of bring it to their attention, I think Sara would say this, they'll lift those burdens if they can lift those burdens. And so it's been, this is less work for me. I do have a lot of other responsibilities, but this is less work for me. It's interesting to find out. It's interesting to sort of connect dots. It's interesting to sort of help people that we can. And I don't mean that we're, throwing open the doors of a prison or anything and making everybody happy, but we're making some people happy, and we're making progress, and we have changed the attitude of the institution that they do want to make this better. Again, it may be altruistic. We want to be good to all these people because we want to be good to all people, but it may also be business, that we don't want these people leaving. People who are burnout leave, they talk bad, they deliver worse patient care. So there's a good business case to be made for taking care of this. For whatever reason they do it, and Sara and I are at the sort of tip of that spear, and I'm proud of the stuff we've done.
I do want to say that, how they say companies succeed when they hire the best people and they take care of those people, right? And that's, I think, Cook's, value system. And I think our organization is very unique in that we have had a lot of support for what we're doing. I think part of it, yes, it makes a good business case, and it is the right thing to do. And I think Cook is smart in understanding and acknowledging both of those things and allowing us to do the work that we do, because they want to be an organization that hires the best people and takes care of those people. So I think that's part of why we have had some of the success that we've had, is we've had some buy-in from our leadership. So how did I get into this position, and how did this work become a passion of mine? So from general pediatrics to focusing on physician well-being, right? I will say that part of it is my own personal experience with, I guess it was a facet of burnout. At the time that I started getting more interested in looking at ways to improve the system, honestly, because I could only do so much in my own sphere, right? To make things better for myself. At the time, I had a full pediatric practice. I practice shared with a colleague. I had at my home environment 4 young kids. I have an older daughter and a set of triplets, and I was out for 3 months after having had them, and back to work. And I remember that experience was, I didn't think twice about it. I thought, okay, I got 3 months. That was beautiful. We got to, be home with them and raise them for that period of time. But afterwards, it was back to work, and I didn't really think twice about that until I got back to work, where it was hard to, continue to breastfeed and pump throughout the day and still manage patient care and all the volume of things that needed to be done in the span of 8 to 10 hours at work. and then go home and do all of that. And so I think with trying to balance, with that balance, it's really never a balance. You feel always like you're shortchanging somewhere, right? And I didn't realize it at the time, but I do believe that I was starting to experience some components of burnout. And then lots of things happen in people's lives that, are just, you don't even realize what's going on. But we had a lot of strain. I don't know if most people know, but I think the statistics for marriages surviving through multiples is like pretty low. And, there was strain with that, strain with, getting back to work in that capacity. You never go into pediatrics and think you're gonna not do your best. I mean, these are people's kids. And so that's a heavy, and, the gravity of that never escapes me. I always go into work, fully try to be prepared, try to take care of myself so that on a day that I'm going into clinic, I'm 100% there. But then where do you shortchange, And so that was challenging. And then we had some difficulties with, my kids are thankfully, by the grace of God, as Kirk said, generally healthy. But we had some troubles with their health. And, my kid had a ruptured appendix and, broken bones, and my daughter was diagnosed with epilepsy. And there were just a lot of things that sort of came up that were added stressors. And then in the midst of that, I lost my sister to suicide. And she also was a physician. And during that period of time, I had already been thinking about, this is hard. How do I continue to do this and do this well and live the life that I want to live? And so I'm kind of an ideas person. I'm always coming up with ideas to, make things better. How can we do this better? How can we make this better? Not only for myself, but for, my colleagues. Because, I'm not in a bubble. I could see other physicians kind of struggling in some of the same ways. But again, where do you find the bandwidth to solve those things? And so, as I mentioned before, I had a medical scribe, and every time I'd come up with an idea, I said, write this down. Put this down. So she literally has a list in her Microsoft Word about all of the ideas that I've come up with over the years for making things better. And so I naturally fell into that by circumstance, I suppose. And then when the opportunity to serve on the Home for Dinner committee came up, I was sitting on the board of directors for CCPN at the time, and my sister had just passed away within that year. And I said, put me on that committee. I need to be on that committee. And so from that, the work just came. And I will say that throughout my life, looking back, and hopefully I still have a long way ahead, who knows? You never know. But looking back on my life, I think, God has really navigated me through this. And I really feel I never would have imagined stepping into a role like this, or, coming out of general pediatrics to the capacity that I have to serve in a sort of essentially an administrative role to help support physicians. But it is exactly where I'm called to be right now. I love the relationships. I love connecting with people. I love finding resources for a need and making those connections. It is incredibly fulfilling. And being able to work with this guy right here, it's not only, it's actually not a downside. And it's funny because, and I probably never told you this, but before medicine, I used to laugh so robustly. And medical school is hard, residency is hard, medicine is hard, but it's so rewarding. But I forgot until recently, until we started working together, how much I really love laughing. And he's pretty hilarious. And to me anyways, and maybe my humor is a little bit off too, probably most physicians' humor is a little bit, quirky. But I do find that even though we have to come up with some solutions for challenging things, I find it so enjoyable because the work is rewarding and because my partner in doing the work is
passionate about it and also hilarious. So
Yeah, we work. I think we work together. We sort of complement where she loves to make charts. I don't like all that detail stuff. I'm colorblind. I can't see all the pastels she uses. But so where I falter and there are big gaps, she fills all those gaps, and she's done the one Mutual Admiration Society. But if Cook people are watching this, she's your champion. She's you've done a great job. To the extent that we've been successful, it's mostly Sara. I have ideas. She has a lot of work. So I think we have found that people who come to our office and say things about how burned out they are, or how parts of the institution is sort of weighing on them very heavily, it's not always who you expect. There are chronic complainers who never sort of bother us, and there are people who you think are the strongest folks in the institution who are truly sort of bothered by stuff. So this can affect anybody. But I'm learning actually from the millennials and Gen Z and all the newer generations that they've sort of imagined the end, that they know this is what I want and how can I reverse engineer what I need, right? How could I get there? If money is your passion, then there's ways to make money being a physician, but there are also ways to have a work-life balance. And many of the newer physicians are sort of imagining that at the beginning. Cook's has been very good. Again, business sense, there's a diminishing number of pediatricians, there's a diminishing number of physicians. People work less long, people work from home, so the workforce is shrinking. And so Cook's has to be the best place to work. And so, as long as you know what you want and you can make a good business case for that, there are a lot of people that work half time. There are a lot of people that work reduced time. There are a lot of people that start late because they're driving their kids to school in the morning. Nothing is I won't say nothing. I don't want to make promises that no one can keep, but most things that are reasonable can be accommodated if it means it's going to prolong your career and make you happier at work. People realize that now. It's not that you come here when I tell you and you go home when I tell you. It's more cooperative. A lot of it is because of she and I sort of harping on people to tell them so, but it's become easier to sort of convince people that making people happy or making the job tolerable is good for everybody, all the stakeholders involved. So I would imagine, the best advice I could give was take inventory, realize what bothers you, realize what might make you happy, and that can change, but realize those things and see if you can advocate for that, because nothing is impossible, but most things we can accommodate, or somebody can accommodate, or somehow you can come to some solution that might help you out, and you don't have to go through that horrible doldrums just because you never spoke up.
I absolutely agree with that. So envision the end, envision what you want your life to look like, what's important to you, prioritize what's important to you, because you don't have to wait to the end of your career to do that. You can live a well-integrated professional and home life from the jump in the world we want to create here at Cook for physicians. We want to be able to foster that from early careerhood so that we are, having loyal and happy physicians that are innovative, that have the space to be innovative. And so there is hope for us. There is hope for medicine. There's hope for physicians here at Cook because, well, one, we're looking at it. Two, we're not shying away from the hard things. We're willing to do the work that it's going to take and reimagine what medicine can look like. And Kirk and I are here to advocate for that. And so reach out to us, ask us, if we don't have an answer, if there's no known solution, that's even more exciting because we get to be innovative in trying to figure those things out. So I think that's pretty much the crux. Envision what you went into medicine for, what your life looks like now, what your short and long-term goals are, and let's just make dreams come true.